Hey everyone, good afternoon. Thank you for joining today and taking time out of your day for conference. We have a fun conference today. If you can join via poll EV, please do so, but otherwise using the Zoom chat will be fine as well, and I'll monitor that. So let's get started. Today we have a sort of Danny style choose your adventure conference. And so I'll let y'all choose the case. Once again, just a poll EV reminder, and this will pop up on the question slides as well. So I thought since New Year's Eve is approaching, we would do a conference sort of related to that. And I love horror movies, and so figured we could do a I Know What You Did Last New Year's Eve conference. And so it looks like sex and drugs and rock and roll is what a lot of people do on New Year's Eve. And so I thought we would do a conference with these themes. And so a fun fact that I found while researching for this is that sex and drugs and rock and roll, which is a phrase we hear quite often, was popularized by Ian Drury, who's a musician, but first appeared in Life magazine in 1969 in a quote that said, "The counterculture sacraments are sex and drugs and rock." So I thought that was really cool. So if you guys want to chat which topic you'd like to address first, let me know where to head for the conference. Danny, do you want to pick one?
Hey, sorry, Sneha. Let's do drugs.
All right, drugs it is. So we have a case here of a 39-year-old man, Fred, who has a history of tobacco use disorder. You're seeing him in the emergency department with chest pain. Here are his vital signs. He's tachycardic and hypertensive. And on exam, he's anxious, diaphoretic, he's tachycardic, but doesn't have any murmurs. He's occasionally rubbing his chest, but the rest of his exam is unremarkable. And so based on that information, what more questions do you want to know from him, and what tests do you want to order for a person who is having chest pain? Yeah, great. Do you use the cocaine and get a UTOX? Excellent. So yeah, so this is a New Year's Eve conference. He said that he was partying out with his friends, went to a few parties, and reports that he is having pandemic fatigue and wanted to see if cocaine could make him feel better. And so he did do some cocaine prior to arrival to the emergency department. An EKG I'll give you, okay? What other questions? You can chat or talk. All modes of communication are fine.
Sneha, one of the questions we had is chest X-ray, and then have you used drugs before, and have you used these drugs before, and is there any difference in your supply or where you got your drugs from?
Yeah, so he says that he'd only tried cocaine once before and is not a typical user, and he thinks he did the most cocaine he's done in a while. His chest x-ray, which I don't have here, looked normal in the ED. I'll give you guys an EKG and a troponin, and then the last drug used was cocaine a few hours before arrival. All right, great. So you guys are obviously sort of picking up on lots of context clues, right? This is a themed conference, and so you're asking the appropriate questions. I will remind you that in patients over 35 that have tobacco use and are men, we don't want to box ourselves in too much. And so making sure you're asking sort of the classic chest pain questions: where's your pain? What makes it worse or better, and whether the patient has any coronary artery disease history in himself or his family are also important. So just remember to remain broad. But today you're picking up on where we're going here. So here are the results. You also get some other basic labs which look fairly normal. His troponin, and I'm giving you the high sensitivity numbers here, went from 70 to 180. His urine tox was positive for cocaine. And then the ED also got you an INR, which was 1. And so here's his EKG. Would anybody like to interpret this EKG for me? And it can be a brief read, mostly your interpretation.
Apoorva has been volunteered by me to interpret this EKG. Take it away.
My brief interpretation is that it looks like it's sinus rhythm. I see P waves, and then the axis looks normal. The voltages are really high, so I wonder if there's any like LVH, but it kind of seems diffusely all over. And then looking at other things, I see some ST elevations in V2, V3, and maybe V4, but I'm kind of far away from it. So I'd be concerned about a STEMI.
Crushed it. That's why I volunteered her.
Yeah, fantastic job. So impressive. So Apoorva, you picked up on all the right things. The only thing I would mention is whenever you see ST elevations in an EKG, just be sure to look for and then remark upon any depressions that you see, because technically for a STEMI, right, you have to have reciprocal depressions, which in this patient, a little bit in 3, they're not very obvious, a little bit in AVR here, a slight dip there. But yeah, most concerning for a STEMI, quite often we can also see some J-point elevations, early repolarization, especially in patients that have LVH, but these ST elevations in contiguous leads are quite concerning. All right, so based on that troponin change and this EKG, what is your next best step in management for this patient in whom this is occurring in the setting of recent cocaine use? And Danny, if people are chatting there in person, you want to let me know what some like clinical reasoning thought processes that are going on, that'd be great.
Yeah. So Apoorva was just saying that she thinks that this is cocaine related. Not entirely sure if the cath lab would be helpful, which I agree with. And then so then we were debating like whether or not we should calm him down with like Ativan versus giving him aspirin and like hedging our bets. And we didn't necessarily think he deserved like a esmol drip yet. So I think we were sort of between B and D.
B and D, observe with serial EKGs. Okay, great. So here is what I learned about cocaine-induced chest pain management. So first, let's talk a little bit about cocaine pathophysiology and what's actually happening. We'll focus on the coronary artery level. So the first thing is that cocaine increases demand, right? And so cocaine is a sympathomimetic. It increases norepinephrine levels in the terminal, in the neuromuscular junction. And by acting as such, it increases your heart rate, your blood pressure, and myocardial contractility, all of which increase myocardial demand. So our demand is going up. It also, at the same time, decreases supply because it acts on alpha channels. And so it has adrenergic stimulation there. And it decreases nitric oxide production, which is one of our main ways to dilate our smooth muscle cells. And so now we have increased demand, decreased supply. And lastly, it actually is a prothrombotic agent itself. And so it activates platelets and it puts you in a prothrombotic state. And so when you put these 3 things together, you're essentially in a perfect storm for myocardial ischemia, which in some settings can transfer into an MI. Unstable angina, an NSTEMI or a STEMI. And so having said that, for the most part, when you have cocaine-associated chest pain, the American Heart Association has this algorithm for us. So certainly you can try your aspirin and benzodiazepines, which are your first line therapies for cocaine-induced chest pain. And benzodiazepines are one of the medications indicated here to sort of reverse the sympathomimetic and the vasoconstrictive nature of cocaine. So those things you can try, as you all said you want to. You can also try nitroglycerin to help with vasodilation at the coronary level. And then an alternative is phentolamine, which is an alpha antagonist to help relax the muscles there as well. But what you have to be careful about is in patients that are presenting with features of a STEMI, and especially in this patient in whom the high sensitivity troponin essentially doubled, the intervention of choice would be to activate the cath lab. And so you have to call cardiology, and this patient needs to go to the cath lab. And the reason is because we're seeing those ST elevations, and cocaine is a prothrombotic agent. And so in some patients, it truly causes plaque rupture / coronary thrombosis, causing the STEMI. And so that needs to be opened up percutaneously. If the patient is having non-ST segment elevation ACS, cardiac catheterization is still recommended, but doesn't have to be emergent. And then we'll talk a little bit about why we avoid beta blockers in patients that are currently intoxicated with cocaine. And then the patient should be discharged on appropriate therapies that are guideline directed. UCH residents say they're filing it in the extremely good to know category. Yeah, and I thought it is extremely good to know. We see a lot of these patients. The articles that I was reading about this reported that about 32% of patients that present to the emergency department of all the patients that present to the emergency department with substance use, 32% of them are related to cocaine, and then 6% of those have MI as a complication. So this is really important for us to know. So a little bit more about these therapies, right? So you see no level A evidence here. It's not a lot of randomized controlled strong level trials, but the medications that are commonly used and are not harmful are aspirin, benzodiazepines, nitroglycerin. Calcium channel blockers don't really have great data, and so we don't really use those for acute cocaine intoxication. And then phentolamine as a blood pressure reducing medicine can be used. As you can see, beta blocker, really a class 3 recommendation, and these should not be used. And so let's talk about why. And so I think we've all heard that you need to do both beta and alpha blockade. And so what happens is our beta 2 receptors cause vasodilation and our alpha receptors constrict. And so when you block the betas, you have just the alpha receptors firing unopposed, and that can potentially make angina worse. It makes vasoconstricting worse, and there seems to be a paradoxical increase in blood pressures when patients are given beta blockade under cocaine intoxication. And so I would ask that we avoid all beta blockers in cocaine intoxication, especially because there's really no proven benefit. There's some data to suggest labetalol may be safe. You can think about using that like way down the line if somebody had a STEMI or has now new heart failure as a medicine. And metoprolol also seems to be safe, but again, in the acute setting, if you're seeing the patients, please avoid beta blockade and use phentolamine, benzodiazepines as needed. So the conclusion for this case is that our patient was seen in the ED for cocaine-associated chest pain, found to have a STEMI. He was taken to the cath lab. He has atherosclerosis, but no intervention was needed. This stat I already mentioned, so high morbidity here in our cocaine using population. And then there's also higher rates of in-stent thrombosis because, as I've mentioned now, cocaine is a prothrombotic agent. And so if there's ongoing use, there's higher rates of in-stent thrombosis. So think about which patient should really get a stent is important. And then lastly, just to remind you that cocaine very rarely is a false positive in the urine. And so if it's showing up, that patient got it somehow. And in most of our patients, it was self-administered. What questions do you all have about that case? People drink coca tea for altitude sickness. Good to know. Yeah, pretty commonly used in South America. And so the patient says they're drinking coca tea, you can believe them. Okay, fun fact, a line of cocaine has 20 to 30 milligrams of cocaine, and a cup of coca tea has about 5 to 6 milligrams. So if you're drinking like 3 cups, that's a decent amount of cocaine that you're ingesting. And so be thoughtful of that. Yeah, great. Okay, so that was our drugs case. Cool. Bottom line, if you see ST elevations in the setting of cocaine use, that person still needs the cath lab. All right, where to next? Sex or rock and roll?
We have a unanimous rock and roll from the
All right,
UCHS.
rock and roll. Here we go. Okay, so you just had a fun time in Times Square, ushering in 2021. You're walking home in the wee hours of the morning, and suddenly you see a man collapse in the distance. You rush over there, since you're a doctor. You find Ryan, who's a 25-year-old man, per his ID. You do a very quick exam, and you find that his skin is mottled, his lips are cyanotic. You look for a pulse, but you don't really feel one. He seems to be apneic versus hypoventilating, hard to tell. And he has some fixed mid-dilated pupils, so pretty scary. So what are your next steps? Somebody said sex, which we're in the rock and roll category. Start CPR, fantastic. Yeah, you just saw somebody collapse and they have no pulse, so start CPR. This person didn't have sex, they were just attending a rock and roll concert in Times Square. Fantastic. And yep, we're ACLS providers, but basic BLS tells you that you need to ask somebody else to call 911. Is the scene safe? Excellent. Make sure that the scene is safe, that you're safe. And then somebody says that from your purse, you should try naloxone. Okay, fab. I don't have any, but when the paramedics get there, we'll ask them to try some. All right, you guys are doing a great job. So good start. So this is a tough scenario because you're in the community and you just witnessed a cardiac arrest. And so the things to do are making sure the scene is safe, having somebody call 911, and then starting CPR. So let's talk a little bit about the 6 H's and the 5 T's. So I want you guys to cat these to me. Danny, you can shout them out as people shout them out. Just because we're going to be talking a little bit about cardiac arrest here.
All right, Sneha, we're going to go in a line around the room.
Okay.
We're just going to say an H or a T in order.
Love it.
All right, I'll go first. I got hypotension.
Hypoxia. Hypovolemia. Hypothermia. Hypovolemia or hyper.
Nice.
Hyperacidosis.
Corey went with hyperacidosis. our chief resident with hyperacidosis. I'll change that to the H+ sign and not hyperacidosis like a weirdo. All right. T's. Before you're up.
T's. Thrombosis.
Thrombosis. Cool.
Tamponade or tension pneumothorax.
Yep. And one more.
Yes.
It's the one that never applies.
Yep. Danny, you can just say it.
Toxins.
Toxins. Okay, so the 6 H's, I think I heard them all except hypoglycemia, which doesn't actually appear in the newest ACLS guidelines anyway. But you guys got them: hypoxia, hypovolemia or hypotension, hydrogen ion or acidosis, hyper or hypokalemia, hypoglycemia, and then finally hypothermia, which we'll be talking about. And then the T's are thrombosis, both in the form of an MI or a PE. tension pneumo, tamponade, and toxins. Great, good job. So just to think about this, I review these like every couple of months, just in case I end up running a code and need to think about these quickly. So here they are, nicely laid out for y'all. So while I was researching for this topic, I found this paper which just warmed my heart. It's from Norway, and it's titled "Nobody is Dead Until Warm and Dead." And so this is about patients that are having hypothermic cardiac arrest. And some things have to be done differently in patients that are experiencing hypothermic arrest. And so we'll talk about what that is and why. In this article, they did a retrospective sort of chart review analysis of all the patients that presented with hypothermic arrest in Norway between like 1999 and 2013. Prior to 1999, everyone that presented with hypothermic arrest died, but since then, we've learned a lot more about this topic and more patients are surviving. So 9 out of the 24 between that time did survive, and survival rates are about 40% in patients that come in with hypothermic arrest. So how does ACLS change in hypothermia? So hypothermia is essentially a condition in which clinically the patient may look dead, such as this patient did when we first happened upon him. And so remembering that you have to check for a pulse much longer in these patients. They can be very thready. They're often absent, but that's sort of a result of the hypothermia itself. And there's a lot of vasoconstriction going on. So the optimal thing to do is to use echo if available to look for cardiac activity, but obviously in the scene, you're not going to have that unless you carry around a butterfly with you. So check for a pulse longer. Once you start CPR, CPR is harder in these patients. The chest wall can be stiffer than patients who are normothermic. And so it's ideal to use mechanical compression devices if they're available. Otherwise, doing frequent personnel changes to do CPR is helpful. In the article that I just presented, the longest time from CPR to ROSC was 6 hours and 52 minutes. And so as you can imagine, a mechanical device at that point is helpful. So in thinking about shocks, and so after your initial couple of shocks, minimize shocking the patient until they're rewarmed to 30 degrees Celsius. The myocardium at this point is so stunned that it actually doesn't react to electricity. And so the patient needs to be warmer before you shock them. Similarly, you need to withhold your typical ACLS medications because they simply don't work in patients that are this cold or environments that are this cold. And so you have to withhold them until the patient is more than 30 degrees Celsius, and doubling the intervals between when you give them. So if you're going to give like epi every 3 minutes, now do epi every 6 minutes. So just double the intervals. And then the most important thing for a patient that's this cold is to rewarm them internally. So there's degrees of hypothermia based on what your core temperature is. And remember, core temperature here is measured most easily rectally, but when the patient is this cold, it's more helpful to do like esophageal or bladder temperatures. And then to rewarm them internally, you can do bladder irrigation, you can do bowel irrigation. I also read you can do pleural or peritoneal irrigation, which seem pretty intense. And then obviously like you can do external warming, but you must warm internally as well.
Sneha, one other quick teaching point on that. At Denver Health, you guys might see that if someone comes in arresting with a temperature less than 30, they'll go immediately to the OR and they get put on ECMO and they get warmed via ECMO.
Yes.
Until they hit about, I think it's like 35 degrees or so, at which point they get decannulated and transferred to the STICU usually. So you will see people who get put on ECMO for hypothermic arrest.
Correct. Yeah, ECMO is really the modality of choice, but you have to be at an ECMO center to do that. Correct. Thanks, Danny. That's helpful. Okay, so this segues us into sort of the opposite side of hypothermia. So some practical considerations in post-arrest cooling. So as you guys know, patients that cardiac arrested for some of those other H's and T's, once you achieve ROSC, sometimes you'll be asked, hey, do you want to cool this patient? And so we call that post-arrest cooling. Oh, Sneha, how cold is the coldest a person? Yeah, the article mentions that the coldest person they had a core temperature of 13 degrees Celsius. Bird, that's very cold. That person survived. So I don't know if that's the real answer, but sounds like it might. Okay, so back to post-arrest cooling, which we now in fancy terms call targeted temperature management, right? And so I was always pretty confused about this. I wanted to give you guys some practical pearls about targeted temperature management. So who gets this? So targeted temperature management or post-arrest cooling is done in patients that are hemodynamically stable after ROSC, but are not following commands. And so making sure that they're no longer hypotensive, that that you've gotten a handle on their breathing. And once all that is done, you try and see if the patient follows command before you pound them with sedatives. And if they're not doing so, or the GCS is less than 8, this is the person in whom you need to do TTM. How? So practically, we do this at all of our hospitals using automated cooling devices. So you guys have seen these like little sort of rectangular boxes that are nearby the bed using an intravascular cooling catheter. And what do I mean by that? So the company that we use the most is called Zoll, and Zoll makes these intravascular cooling catheters. It basically has 5 ports, 2 of which get hooked up to the Zoll-like machine, and then 3 of them are just regular old ports for nursing to use. And so the reason I'm bringing this up is because once a patient arrests, and you're going to consider cooling them, just remember that you have to put in a Zoll cooling catheter as opposed to a regular triple lumen or whatever else you're going to put in there. So if the patient is down in the ED and they call you up with a patient that's just arrested, see if they can put in a cooling catheter for you right away, because that can be used both as a central venous catheter and as a cooling catheter. And so this is just a practical thing that I remember I have to do in patients that I'm going to cool. Otherwise, you're going to have to exchange catheters. What are we going to do with TTM? So you're going to cool the patient to a targeted temperature preferred by your hospital and your intensivist. There's some debate about what temperature you should use. And it fit inside a cordis. I don't know. It has all these fancy balloons on the end of it. So I would risk not carrying them. So I don't know the answer to that. Danny might know.
Yeah, Sneha, it cannot fit inside a cordis, so it has to go in its own location. And the kind of semi-confusing thing is you have to know which type of catheter you're using because they're different sizes. And for the longest ones, they often don't fit in the right IJ because like one of the cooling balloons will be left outside of the body. So they usually either need to be placed in the left IJ or one of the femoral veins, which is also nice because then your right IJ is still open for a
Awesome.
perk.
Thanks, Danny. Great. Okay, so back to what? So you're going to cool to a temperature that you're targeting. Once you arrive at that temperature, you need to stay at it for at least 24 hours of maintenance, and you're going to slowly rewarm the patient. And then lastly, remembering that we very commonly see complications when we therapeutically cool somebody. And so what are these things you need to watch out for? So bradycardia is really common. Other arrhythmias are also common. QT prolongation. And so thinking about whether you're going to give these patients more medicines that prolong QT, be mindful of that. You don't want to send them into another arrest. Coagulopathy is super common in these patients. Hyperglycemia, we think, is due to essentially muscular inactivity and not taking up any glucose. Shivering can be a common problem when you're first starting to cool them, and so we use opiates as our first-line medications to help with shivering. And then hypokalemia and hypophosphatemia are very common as well. And so these patients need some routine labs to monitor for some of these things and then replacing them as needed. When the patient is getting rewarmed, sometimes they can like overshoot and be febrile, and so you can use Tylenol to help with that. What questions do you all have about targeted temperature management? All right, cool. Just wanted to show this article, since I mentioned there was some debate about 33 versus 36. And in this article, they found that 36 was non-inferior essentially to 33. So it just depends on what your institution wants to do. Just pick a number and sort of stick to it. All right, so that was our rock and cold case. Sex is last, so I'll just take us there. Okay, so for this case, you're seeing Jennifer, who's a 26-year-old woman. She's in urgent care for vaginal discharge. So she had sexual intercourse with an anonymous partner on New Year's Eve. Her vital signs are normal. Her pelvic exam is remarkable for thick gray discharge, but no cervical motion tenderness. And the remainder of the exam is non-contributory. So what tests do you want to order for Jennifer? GC, gonorrhea and chlamydia. Good. Someone added HIV to that, okay. Thomas Johnson says wet prep. Awesome, thank you, Thomas. Thomas, can you mention what you were looking for on the wet prep? Trichomonas, okay, good. Good, we'll talk about that. Sounds like BV, wet preps at DH reflex to trick, great. RPR, somebody also wants to test for syphilis. All right, good work. I think you guys got them all. I'm gonna have a couple more in there. Before I give you the results of all of these tests that you asked for, I want to remind you that we see patients like this quite often in our primary care clinics and the urgent cares, and to remember that we're there not to judge them or question them about their decisions, but that we're there as a guide to help them make the safest and the healthiest decisions possible. And so just be thoughtful about how you approach patients like Jennifer or like Fred, who was doing cocaine. All right, so for the results, you got a urine pregnancy, not from this sexual encounter, but just to make sure that patient isn't pregnant, because treatment considerations are slightly different if the patient is pregnant. You got Neisseria gonorrhea, which was positive, chlamydia was negative, trick was negative, and then the wet prep had no yeast organisms seen, and no BV either, Thomas on there. I want to comment on one thing here. So we'll talk a little bit about the HIV that all of you wanted and what considerations have to be made for that. But just remember that that trichomonas, in this scenario, it would be helpful if you ordered the trichomonas PCR test, because wet prep is actually pretty poor when it comes to specificity for trichomonas. And so if you're worried about it, I would just order the PCR, the NAT test, as opposed to relying strictly on the wet prep. I mostly rely on the wet prep to look for BV, like Thomas mentioned, and then for fungal infections or Candida. And then Thomas asked, did we discuss if she used contraception? How many days later are we evaluating? Thomas, this is like 1 week later, and she did not use contraception. Good, yeah, and Thomas says auto PCR because of the low specificity on that wet prep. All right, great. So she has a gonorrhea infection. What treatment do you want to use? All right, whoever answered B is correct. And so you want to use ceftriaxone 250 milligrams IM and azithromycin 1 gram PO. And so let's talk about different managements for some of these conditions. And so the reason I wanted to talk about this was it appears on boards. We see it all the time. And I always got confused about when to use double therapy versus not. And so the way it works is if you're seeing somebody for cervicitis or urethritis and you don't really want to wait for those PCR results to come back and you're going to treat them empirically, you want to use double therapy. So you're going to use ceftriaxone and azithromycin. And here what you're doing is you're covering both gonorrhea and chlamydia. Say you had the time to get your PCR back and it comes back with a Neisseria infection, but the chlamydia was negative, such as in our case, you're still going to double cover. And here you're double covering because there is now resistance to cephalosporins coming up in our Neisseria gonorrhea bacteria. And so you're adding azithromycin for resistant Neisseria. If it's reversed, so if chlamydia is positive, but Neisseria is negative, you don't need to double cover because you're confident this person doesn't have Neisseria. So you're just going to use azithromycin. And then if the patient has trichomoniasis, which we were looking for here, but she didn't, if that's the case, you're gonna, there are two regimens. So you can use metronidazole 2 grams just once, or you can do the 500 milligrams. I think it might be BID, but you can check me on that for 7 days. So 2 acceptable regimens there. But remember that for trichomoniasis, both partners need treatment. And if the patient is pregnant, you need to use topical clotrimazole because metronidazole is class X in pregnancy. The other thing I wanted to mention here is if the patient is allergic to azithromycin, in all of these cases, you could just substitute all of these regimens for doxycycline, 100 milligrams BID for 7 days, which is why the last answer here is incorrect because 3 days is too short a duration. So do this last option for 7 days if you can't do any top 3 regimen. And remember, I'm not including yeast, PV, pelvic inflammatory disease, epididymitis, or disseminated gonorrhea in this scenario. And then lastly, I just want to remind you that fluoroquinolones, which used to be the treatment for some of these infections, are completely fallen out of favor now because of the high levels of resistance to fluoroquinolones. And so you should not be using them. All right, so a lot of you wanted to get an HIV for this patient. And so when do you want to test this? All right, a little bit of controversy here. Somebody says test now, which is essentially would be like 1 week after her exposure. And then somebody said test in 1 month. So I saw a lot of you wanted an HIV. I would want one too, but the question is when to get it. And so this is a little bit tricky. Remember that the HIV test, which is preferred at most of our hospitals, is the HIV-1, HIV-2 antibody. And so your body has to have time to develop antibodies to an HIV infection, right? So now is not the time to get that test. So here's the timeline of how it works. So you get infected day 0, and then about day 10 is when the HIV RNA starts to sort of be present in the bloodstream. But it really isn't until, in the 20s of days to really after 1 month that your antibody can be detected in the blood. And so the teaching is like between 27 to 72 days. That's a big window, right? But you really don't want to test the person until about 1 month after exposure for HIV if you're using the antibody test. If they had a really high risk exposure, like the other person had HIV and the condom broke or they didn't use a condom, then you can test for the RNA earlier, or you can do the P24 antigen test. Some of our higher generation antibody tests can detect lower antibody levels, but again, you're not really going to see the antibody in that early, super early period. The other thing to consider here too is, remember, we have post-exposure prophylaxis. And so if you're really worried about the risk, or if the other patient had HIV, you can consider getting this person an ID consult to get started on post-exposure prophylaxis, right? Which is something we commonly use in occupational exposures. So just remember that the HIV test we get is an antibody, and your body needs time to develop those antibodies. And so you can't get the HIV test now. The patient has to come back and get it. Typically, it's recommended that you test at 1 month and then 3 months, just to make sure that you're catching sort of this optimal time period where you're gonna catch that antibody. So the conclusion for this case was that we saw a patient for Neisseria gonorrhea cervicitis. She was treated with ceftriaxone and azithromycin. There's no need to test for clearance for urogenital infections, so it doesn't need to come back. You will counsel the patient on safe sex practices, and then HIV test sometime in the near future, but not now. And so, our objectives for today then were to identify when to choose 2 antibiotic regimen for gonorrhea and chlamydia. We understood cocaine pathophysiology and treatment choices. And then lastly, we managed hypothermic arrest and talked about post-arrest hypothermia. And the self-directed learning today, I wanted you all to look up the etymology of Neisseria gonorrhea. Neisseria part comes from the doc who discovered it, but the gonorrhea part of it is pretty interesting. So I encourage you to look it up. Remember that these organisms are generally found as these sort of diplococci inside a neutrophil. Cool. And I wanted to see if y'all had any questions.
Sneha, I did the self-directed learning just now, and that is interesting.
Yeah, I don't know if it's, I kind of was already edgy with the sex, drugs, and rock and roll, but not sure that I wanted to bring up the gonorrhea part.
Yeah, we'll defer that one for a later. People can look that one up themselves. I encourage everyone to. It's interesting.